Hi, good morning, everyone. It's 9:30 a.m. Indian Standard Time, and we are joining in from multiple countries. We are CMAAO, 19 countries associations, joined with US, Spain, and a lot of other European countries. We bring topics every week. We meet every week, and we come across various issues which are going on. Today, we have this is 115th International Weekly Session. Today, we have maternal obesity, the topic. And to present this topic, we have two speakers. First, Dr. Madhu Goyal. She's an MBBS and MD doctor, Associate Director for Fortis Law Firm. She's an ex-Vice President and Founding Secretary for DGFC. She's a member of AOGD Endoscopy Committee, Safe Motherhood Committee. She's a course coordinator for FOGSI, Certified Laparoscopy Training Program. She's a winner of Dr. Pratibha Tiwari Award for the Best Postgraduate and Dr. Abdul Kalam Azad, and she had a lot of publications under her name. We also have Dr. Raghu Raman. He's a director for neonatology, Fortis Law Firm. He's also the founder of Amara Human Milk Bank. He's graduated from Bangalore Medical College. He's postgraduated training in pediatrician and super specialty training in United Kingdom from 1994 to 2004. He's returned back to India in 2004 to set up a state-of-art center at Fortis Law Firm. He has presented a lot of papers in England on his subject, and he has also started Breast Milk Foundation, which is non-to-profit organization which specializes in human milk bank. Over to Dr. Madhu.
So, thank you very much, Saurabh, for a very warm introduction. And just to give you a little brief, both Dr. Raghu and I work in Fortis La Femme. It's a state-of-art niche center for obstetrics and gynecology, and generally for other women healthcare diseases. So today we bring to you a perspective on maternal obesity. I will be speaking from the mother's point of view, and Dr. Raghu will be taking up the children and neonates, the problems that we encounter when the mother is obese. So we all know that the incidence of obesity is increasing. And just give me a minute, please. And today, it is the most common medical condition in women in reproductive age. And up to 30% of women in the reproductive age are obese. And the prevalence of BMI more than 30 kg per meter square is gradually increasing year on. It is an important public health problem with implications not only for the mother and the baby, but also for future generations. And I believe that it should receive far more attention from the medical fraternity than it is receiving now. So, what is obesity? Currently, we take BMI as the marker for obesity. So, obesity is defined as a BMI of 30 or more, and it has three categories, with obesity category 3, or what we call super obese women having a BMI of 40 or more. Category 2 is between 35 to 39.9, and category 1 is between 30 to 34.9. Now, why are we discussing maternal obesity? Because it has not only increased risk of complications during pregnancy, making life little harder for the obstetrician, it also has long-term health risks to the mother in terms of hypertension, diabetes, cardiometabolic risk. I think we are all aware of what obesity entails in terms of health risks. So it also has increased risks to the baby in pregnancy, which Dr. Raghu will be talking about. There are long-term health risks to the baby and the impact on future generation as well, which I think is very worrisome. So we will talk about this individually. Now, how does it complicate the pregnancy? It increases the incidence of gestational diabetes, gestational hypertension, venous thromboembolism, pelvic pain during late pregnancy. There is increased chance of obstructive sleep apnea. Then, if there is a cesarean or even if there is an episiotomy, increased chance of a wound infection, postpartum complications like anemia, weight retention, depression, and the lifetime risk of cardiovascular diseases are increased. So even during delivery, we have increased chances of failed trial of labor, rise in cesarean births, and increased maternal morbidity. In the baby, you have increased chances of structural birth defects, macrosomia, that is the heavier baby at birth, prematurity, hypoglycemia, stillbirth, increased chance of neonatal intensive care admission, and the babies also show an increased incidence of asthma, autism, attention deficit, hyperactive disorders, and early development of metabolic diseases in these patients. So if you see the odds ratio for all these complications, recurrent miscarriage, spontaneous abortion, and a couple of congenital defects in the baby, they are all increased as compared to a mother with a normal weight pregnancy. So even during pregnancy, the incidence of gestational hypertension, preeclampsia, GDM, preterm birth, even stillbirth, just see how much the odds ratio is increased as compared to a woman who starts the pregnancy with a normal weight. So when we talk about the impact on the baby and long-term impact on the baby, by this we mean that normally we believe that the cardiometabolic diseases in adult life, that is blood pressure, cardiac diseases, is governed by the genes and the postnatal environmental factors like stress, eating habits, lack of exercise, etc. But recent research has shown that there are two other factors which play a role. One of it is pre-gestational maternal nutritional status, and the other is maternal diet. So there is this Dohart theory or development of origin of health and disease theory, which has defined and highlighted the role of both nutritional status and maternal diet on both the pregnancy outcome and the risk of chronic diseases in the baby. So this is what the Dohart theory says, that in normal development, there is a normal gene expression. But if there is intrauterine stresses during the developmental stage, there is an abnormal gene expression. That means that the genes are expressed differently without any change to the structure of the DNA. And this falls into the category of epigenetics. So there is a concept called fetal programming, which points towards the in utero environment and its critical role in healthy human development. That means certain events occurring during critical points of pregnancy may cause permanent effects on the fetus, which may last long after birth. So you can see how it will impact the future generation. Let's say the mother is obese. Her lifestyle, her preconception weight, and weight during pregnancy are increased beyond limits. So she is transmitting it to the baby. The baby is born with inborn susceptibility to cardiometabolic diseases. Then this baby is subjected to postnatal environmental stresses. And when finally they become parents, they transmit the same problem to next generation. So if you will just stand back and look, you will understand that this is a transgenerational flow of epidemic that we are seeing, and we are transmitting the problems to the next generation. So pregnancy offers a window of opportunity to program the future health of both the mothers and offsprings. And obstetricians are uniquely placed to modify this transgenerational flow of cardiometabolic diseases. So naturally, the counseling should start when the patient comes before she is pregnant. And when we counsel such patients, we need to tell them about the risk of being affected by obesity and the advantages of weight loss. The benefits of weight loss not only include improving the pregnancy outcome in terms of reducing the risk of miscarriage or blood pressure or preeclampsia or gestational diabetes, but it also reduces the long-term risk for the mother. Not only that, we need to emphasize the advantage of weight loss before pregnancy to the future health of the progeny. This is very important. So obviously, weight management will involve counseling about diet and exercise. And we need to emphasize that not only the physical advantages, but it offers mental advantages also in terms of reduced anxiety and depression. So, but this counseling is not easy because there is a reluctance on the part of healthcare givers. They feel that the patient feels judged and offended. Even in my own practice, I've seen the moment you start pointing out that you are overweight to any patient, they don't like. They usually come out with the fact that even their friend was obese, but she's had a normal delivery or she's had a normal baby. So, not only from the point of view of the healthcare, but even patient level factors are there. Patient acceptance of her weight problem and her willingness to change behavior, that is very difficult to change. So, of course, this is coupled with lack of well laid out strategies for counseling. And there is a practical problem, and that is exercise can actually be physically and mentally difficult for obese women because of lack of physical conditioning and embarrassment regarding their figures. So, we need to work on our counseling techniques. So apart from the counseling about diet and exercise, we need to start folic acid supplementation so that we decrease the risk of congenital abnormalities in such women, and vitamin D supplementation. And of course, if she is on any weight loss medicine, we need to stop that at least a month prior to when she is planning a pregnancy. And these women should be prenatally assessed for cardiac, endocrine, metabolic, and renal abnormalities. So what about when these women, they're already pregnant and they come to us? So in such women, we need to tell them that the gestational weight gain, the weight that they need to gain during pregnancy, should be limited to about 5 to 9.1 kg depending on their individual BMI. And there are well-defined guidelines laid on how to achieve this, which tells us that the weight gain per week should be limited to these ranges. So the most successful intervention to prevent excessive gestational weight gain during pregnancy again involve physical activity and diet. So you have to tell them about each thing. First, start with the fact that there is no weight loss which is recommended during pregnancy. I don't know what happens in different countries, but in India, the moment the woman comes in and she is pregnant, somehow her focus changes towards health, and she wants to know how healthy can I get during pregnancy. So we need to emphasize that we are not looking at weight loss during pregnancy. We are looking at limited weight gain during pregnancy. So we need to specifically tell them about diet, their calorie goals, use of a structured meal plan. It is always better to tell them to monitor the calorie intake on a daily basis by herself, and frequent weight measurement, because the moment she tips over, she will cut back on her food. And behavioral strategies. So when we talk about diet as a diet, it always creates problem. You need to tell them that it has to be a change in how they think about food. So you have to tell them the myths about how much and what to eat during pregnancy. So pregnancy is not a certificate to start eating whatever they want. That is the other end of spectrum. We see, oh, now we've got pregnant, we can have our ice creams and our pizzas and colas. So you need to tell them that the energy needs only increase in the later half of pregnancy, and that too by only 150 to 200 calories per day, which is actually 2 chapatis and not more than that. So increase in fruit and vegetable intake to at least five helpings per day. And most of them, they get help by referring the patient to a dietitian for assistance. So again, about exercise, you have to be very specific. First, they need both aerobic and muscle strengthening activities. They need to start the exercise slowly. Sometimes I need to tell the patient that even 5 minutes of exercise, please go out and walk at least for 5 minutes and then increase on a weekly basis. So they have to be told that by exercising, they do not harm their baby. And in fact, they benefit their baby. So you have to tell that how to change the strategy for exercising every week or on a monthly basis or trimester wise basis. Also, very importantly, you need to tell the warning signs on when to stop exercise. So RCOG recommends that you need to exercise on at least 5 days of a week, at least minimum. And hopefully in the near future, we will see that exercise prescriptions will come into vogue and we will actually write down on our prescriptions on what the patient needs to do. So this is easier said and done, easier said than done. So obviously we need to, change our strategy to deal with this. So educating the healthcare providers is one. Provision of written material, something that we can hand over to the patient because we all lack time in our OPDs. And there have been studies which show that teleconnect on this is very effective. So sensitive and trained specialists with individual focused attention should be available, and repeated emphasis on the benefits. Each antenatal visit, you stress on the fact that weight is a very important limiting factor in her case. And of course, you have to repeatedly tell her that whatever diet you are prescribing and whatever exercise levels you are telling them will result in no harm to the baby. So apart from the advice on exercise and diet, other factors need to be taken into account. And one very important thing is the prenatal testing. We've already seen that there are more structural abnormalities in these babies, combined with the fact that the accuracy of fetal imaging in pregnancy deteriorates when the mother is obese. So the quality of your scans goes down, and the biochemical tests that we do in pregnancy for genetic testing, they also come with their own share of problems. So this needs to be emphasized to the patient, and probably such a patient would require more scans than a normal patient. For example, for a normal patient, a normal weight patient, we will do an early anatomy scan. We don't do an early anatomy scan. We do a detailed scan only at 20 weeks. So in such patients, we would like to do an early anatomy scan at 16 weeks. Later on in pregnancy also, clinically, it becomes very difficult to pick up whether the baby is growing normally or not. There is so much fat on the abdomen that you're not able to feel the uterine height. So it is preferred that you do a increased ultrasound surveillance in such patients. So just to summarize the main points, you start folic acid supplementation before pregnancy. There should be an increased surveillance for complications of obesity, which are blood pressure and diabetes. So regular checking of blood pressure for such patients. And if the patient has any additional factors like age or an IVF pregnancy, aspirin prophylaxis needs to be started. For diabetes detection also, there should be an early screening and weight gain to be limited according to the BMI. And in super obese women, that is in patients who have a BMI of more than 40, you might want to consider a delivery between 39 to 40 weeks because of the increased risk of stillbirths. Also remember that super obese women, when in labor room and if they go in for a cesarean section, would require additional um, precautions, which I will be detailing just now. So when we talk about the mode of delivery in obese pregnant patients, please remember it is not an indication for a cesarean section. We can allow her to have a normal delivery, but when we induce such patients, there are higher chances of failure. So for such patients, we would like an early establishment of venous access. We all understand that just getting an IV cannula in these patients can be a difficult task. So we have to consider that the labor process can be a very prolonged one in such patients. And they have an increased incidence of postpartum hemorrhage also. So there should be an active management of the third stage of labor. So despite the fact that we allow them for a normal delivery, there is an increased risk of cesarean because of the associated complications. They may have gestational diabetes, hypertension with obesity, associated macrosomia. That means the baby's birth weight may be more than normal, and there is a prolonged duration of labor. There may be a non-progress of labor, and there are increased chances of fetal distress. So all these may prompt a cesarean section. Now, when we talk about cesarean section, it comes with its own set of difficulties. And primarily, anesthesia considerations are one. Because of the short neck, there may be a difficult intubation, and it is very difficult sometimes to put spinal in these patients. So dose of certain drugs that we routinely use may need to be altered due to the body weight. And if the patient has an additional sleep apnea, it may cause additional problems. So associated problems like diabetes, etc., need to be taken into account. So what we need to do is prepare the OT properly for them. They need a larger table. We need to book the OT for a longer time, and we need to have adequate number of personnel in the OT. Just for shifting her from the trolley to the OT table would require extra personnel. So there are other considerations which are a little technical, like where to give the skin incision, etc. But um, any person who's operating on these patients and your OT team, OT staff need to know that this is a high risk patient that we are dealing with. So as I said, the operative time is more. There is increased rate of blood loss. Then post cesarean section, there is increased chance of wound breakdown and infection and uterine infection in terms of endometritis. So all these need to be covered with probably an extra dose of antibiotic. So such patients would require venous thromboprophylaxis. And apart from the routine compression devices that we use, they need to be given low molecular weight heparin, which needs to be, the dose needs to be altered according to their weight. So anyone between 90 to 130 kg would require 7,500 units daily. Now, once the delivery is done, even for breastfeeding, we have seen that they are less likely to breastfeed as compared to a patient who is normal weight. And this is because of decreased initiation of breastfeeding. The milk supply is also less than adequate. And there can be a mechanical difficulty in latching because of the increased breast size. So we need to push them for breastfeeding. And while these are the normal holds that we advise, in obese women, it is the football hold, where the baby's head is facing the maternal breast that we are looking at, so that she can see when the baby is feeding. So again, just a summary in the postpartum period, we have to encourage breastfeeding. You need to tell them that it is important for your baby. Appropriate contraception advice should be given, and preferably a non-oral contraception should be given. I mean, oral contraceptive pills are not the preferred method, and we should probably use an IUD or an implant in such patients. So very importantly, in the inter-pregnancy interval, we have to tell them, we have to encourage them, we have to push them to lose weight. This is very important. Even in normal weight patients, we have seen that the inter-pregnancy interval is very important. On an average, they tend to retain 7 to 8 kgs at least in the inter-pregnancy interval. So in case, of course, if they've had gestational diabetes or preeclampsia, appropriate monitoring needs to be done on a long-term basis. And as I said, obese women, apart from the physical issues, also are more likely to have mental issues in terms of depression and anxiety. And we need to look into them. Probably a referral to a psychologist or a psychiatrist also may be required. So just a line about how to deal patients after bariatric surgery, because increasingly bariatric surgery is becoming common across the world. And we know that there are different types of bariatric surgery which impact the pregnancy differently. So the important thing to remember is that post-bariatric surgery, you need to delay the pregnancy at least for 1 to 1.5 years. And this is because just after bariatric surgery, there is a rapid weight loss and the patients are in a catabolic time frame. So if they get pregnant at this time, it will impact the nutritional status of the baby. So contraception at this time is very important. And again, a non-oral contraception should be considered. So just for these patients, they are at a higher risk for being nutritional deficient. So we need to check the protein, iron, folate, calcium, vitamin B12 and D levels at the beginning of pregnancy, and they should be monitored every trimester, and adequate nutritional supplements should be given to these patients. So when they do get pregnant, nausea, vomiting is often taken as a part of being pregnant. However, you need to rule out delayed post-operative complications of bariatric surgery. So early consultation with a bariatric surgery, with a bariatric surgeon, the surgeon who has done the surgery for her is preferred. And the only difference in pregnancy care being after bariatric surgery and super obese women would be that to monitor the sugars, you need alternative screening method and the standard glucose tolerance test that we do for normal patients, where we give 75 grams of sugar and do the sugar value after 2 hours. That should be avoided because that will result in abdominal cramping, bloating, nausea, vomiting, and diarrhea in such patients. So again, the drug dosage needs to be modified. Extended release preparations are not recommended. And if you are prescribing any drug where the drug level is critical, you may need to check the drug level to ensure that it has a proper therapeutic effect. So mode of delivery, again, bariatric surgery is not an indication for cesarean section. We should allow the patients to go into normal delivery and cesarean section only if that is not possible. So thank you very much. Just concluding, I think it is time that all of us pay a lot more attention to the patient's weight than we are currently doing and push them for an ideal weight gain, ideal pre-pregnancy weight. Thank you.
Excellent presentation, and I think we will go to the next presentation, and we will hold the question answers after the second presentation. Can I invite Dr. Raghuram Malay for his talk?
Hi, good morning, everybody. Just trying to get the can you see my screen now?
Yes, we can.
Hi, good morning, everybody. It's a great pleasure to be part of this discussion today. I'm just probably going to just start off where Dr. Madhu had stopped her talk, and she sort of covered the maternal part of complications seen in maternal obesity. And I'm just going to talk to you a little bit about the neonatal outcomes and probably look a little bit beyond that as well into what happens to the offsprings of maternal obesity in terms of infant problems, child problems, as well as into the adult problems, and look a little bit about the epigenetic modifications. Maternal obesity actually has become a huge epidemiological problem, and this problem seems to be increasing. And it has always been a problem, but we're recognizing this as a major impactful issue from an epidemiological perspective for the last 10 to 15 years. The whole idea of today's talk is just to try and understand how maternal obesity has an impact not only during the immediate neonatal period, but beyond that, and probably into the adulthood as well for these offsprings of maternal overweight or obese mothers. I do understand that the audience today is very varied, so I will not go into very detailed discussions about neonatal management or the outcomes for these babies, but more look at it as a social problem which needs to be addressed. And the idea is that as healthcare givers, we need to be aware, like it was mentioned before, counseling is a very important part, maybe even preconception counseling is very important. So we need to just sort of get a perspective of what these problems are and how it is going to affect the babies of these maternal obesity problems. Maternal obesity is very rarely discussed in most forums, at least in our neonatal forums and in the obstetric forums. It's not been a topic which is discussed. So I'm really glad that we are actually having a discussion on this. So what I'm going to do today is talk to you a little bit about, first we'll look at obesity on neonatal outcomes. How does it affect at birth or in the first month after these babies are born? Actually, like we were discussing, it progresses on beyond neonatal outcomes. The child may be okay during the neonatal period, but may still end up having problems during infancy and childhood. We just have a quick look at that. And interestingly, about even if the child is okay and there's been no immediate effect, even in childhood, a lot of these offsprings born to maternal to obese mothers may have problems later on in adult life, which is sort of crossing over to Barker's hypothesis, although his hypothesis is mainly related to undernutrition and what happened to these. A similar sort of comparison has been derived about maternal obesity, and we'll have a quick look at it. And most of these adult diseases of fetal origin are based on epigenetics. I'm not a geneticist per se, but I'll try and see if I can just decode this epigenetics in a very basic manner so that we understand what this is all about. And then lastly, we'll look at the direct impact of obesity on epigenetic modifications and how does it affect during the later on time of these people. So just for us to understand, this is just a snapshot of the WHO classification of obesity. I think it's very important to understand this, to understand all the data that I'm going to share with you in the next 10 to 15 minutes. Obviously, underweight is less than 18.5. Overweight is between 25 to 29. And obese is then classified into three classes: class 1, class 2, or class 3. Some people just classify obese, class 1 as obese, the other one as morbid obese, and class 3 as super obese. So these are synonyms that are used. We just need to understand this before we move on to the next slides. So let's look at the neonatal outcomes first. Obviously, there's a huge increase in birth defects. The meta-analysis is clearly shown, which was also addressed in the last talk. You have a huge incidence of birth defects such as neural tube defects, spina bifida, very important cleft palate, cleft lip and palate, all of them are increased, anorectal malformation. So a huge array of birth defects which are increased due to maternal obesity. Stillbirth is increased. This is the odds ratio, which was published in ACOG, which is slightly older study, but still shows, other than one study, almost all studies showed that maternal obesity led to stillbirths, and the odds ratio increased by almost 2. So it's a very significant effect on stillbirth. This was a very interesting study from Sweden, again, an epidemiological study, which had closely 2 million mothers, which was published in 2017-18. And they, again, divided based on the BMI, they classified them to different levels of overweight and obesity. And what they clearly showed had maternal obesity had a clear impact on premature deliveries. They divided the prematurity into early prematurity, late prematurity, and moderately late prematurity. And in all these groups, there was a definite increase in the percentage of preterm deliveries. Obviously, more so being towards the early pregnancy and more so being towards higher BMIs. So if you were in the super obese category, the percentage almost tripled of having a very preterm baby, and which has got a significant impact, long-term impact on the outcome of these babies. So there's a definite impact on prematurity for sure. Some other people also looked at, there were some other meta-analysis which showed that the odds ratio for birth asphyxia, that's compromised APGARs at 5 minutes and 10 minutes, the blue lines being the 5-minute APGARs and the red line being the 10-minute APGARs, again, across all categories of overweight and obesity, was much higher compared to a normal weight offspring. What was interesting is they also showed that there was an increased incidence of meconium aspiration in these babies, again distributed across all the spectrum of the obesity spectrum, and very significant increase in neonatal seizures, which again has a very long-term impact. Rather than just having just a neonatal impact, it can also have long-term impact. So very, very significant numbers. This was the American study. This was by far the largest epidemiological study, which had more than 20 million people over a period of studied over a period of 2 years. And again, they looked at various different morbidity outcomes in neonates. And again, they showed sort of similar trends to the Swedish study. The 5-minute and 10-minute epigars were obviously disturbed quite a lot across the increasing BMI ranges. Neonatal seizures again was significant. They, however, did not show such a great increase in neonatal admission to the neonatal unit or immediate ventilation, other than the super obese category. But again, had a very distinct trend towards prematurity. Early prematurity, moderate prematurity, and late prematurity, all of them. Again, the impact being the highest towards the early prematurity, and especially in the moderately obese and the super obese people, or morbidly obese and super obese people. This had the maximum impact in this category of people. So clearly, there's a huge impact on neonatal outcomes. Another study, which was in 2008, a meta-analysis showed when they corrected and they removed prematurity out of it, still even the term babies, NICU treatment or NICU admission was much higher, which has both impact on the psychological aspect as well for the mother, for a baby to come into the NICU, as well as an economical impact to the family. The same 2008 study also showed there was an increase in all the other neonatal morbidity outcome patterns requiring resuscitation, respiratory distress, even in term babies, again correcting it for the prematurity. But an interesting aspect was it did not show there was an increase in jaundice, which is a very common neonatal problem that people encounter, and hypoglycemia, which was a very interesting topic. But just to summarize, in terms of morbidity, even after prematurity was a very important factor, which resulted from maternal obesity, but also other problems in term babies increased. So they needed more admission to units, and some of them had long-lasting impact in terms of neonatal seizures, which can affect the child later on in life. Other than morbidity, it also has an impact on mortality. And this was a very interesting study from the Southeast Asian region. Again, it had about 2 lakh mothers who were included in this study. And the ones which I've highlighted in yellow is the corrected or the adjusted odds ratio. And they divided them into 4 different categories of mortality. One was miscarriage, stillbirth, early neonatal mortality, and late neonatal mortality. What was interesting in this was if you were underweight, it did not increase the chance of having a miscarriage or stillbirth, but definitely overweight or obesity had a great impact on both these parameters, both on miscarriage and stillbirth. Underweight, overweight, and obesity had a huge impact in terms of, or a significant impact in terms of early neonatal mortality and late neonatal mortality, which was very interesting data, which sort of pointed out that obesity was maybe a larger problem in terms of all 4 parameters, which is miscarriage, stillbirth, neonatal mortality, both early and late neonatal mortality, which is very interesting data. So moving on to from the neonatal period to infancy and childhood, a lot of these babies may not have the immediate effect of maternal obesity, like macrosomia and all the other problems that I mentioned early on. They may be perfectly normal during the neonatal period, but they may still go on to have problems later on in infancy and childhood. And one of the very important parameters, which is infant mortality rate, again from the 2009 epidemiological study, clearly showed that the odds ratio increased quite significantly, both in the underweight as well as in the obese mothers. Obesity obviously had a huger impact in terms of increasing the odds ratio of having higher infant mortality. This sort of data was supported by the more recent Swedish study as well, which showed a much higher increase in infant mortality rate, especially towards the super obese and the morbidly obese patients, where the BMI was higher than 35. So not only did it increase infant mortality rate, but it also increased the chances of having childhood obesity, which is a very important factor. And almost 25 to 30% of the population, the child population now, suffers from childhood obesity, and it's an increasing problem. And if you look at it across all age groups, starting from the age of 2 up to adolescence, up to 14 years, the odds ratio of having an obese child increased if the mother was obese during her pregnancy. And again, like I said, this is across all age groups. And surprisingly, a lot of these babies might not have been macrosomic at birth or during the neonatal period. They did not have any problems during the neonatal period, but still ended up having these problems a little later on in life. So I think that's the important part that we need to understand, that these effects of maternal obesity go beyond just the mother's problem and the neonatal problems later on into childhood. The Swedish study was very interesting. They had, again, a large population of almost 1.4 million children. They were followed on an average of about 8 years. And this clearly showed that there's an increased incidence of cerebral palsy with increasing BMI. And again, the odds ratios increased quite significantly, almost doubled in the super obese mothers to have cerebral palsy, which obviously is a very, very important outcome factor for us. So does the problem stop here? No, it still continues on to adulthood as well. Maternal obesity has a huge impact on adulthood. And even if your child is okay during the neonatal period and during infancy and childhood, they may still end up having other problems, metabolic problems, adult obesity, problems such as diabetes, later on in life, cardiovascular disease such as ischemic heart disease, cerebrovascular accidents, metabolic conditions such as hypertension, hyperlipidemia, renal problems, as well as mental illness such as depression and schizophrenia as well. And most of these problems have been attributed to epigenetics, which we will discuss in the next few slides. And it is based on Barker's hypothesis, which was for underweight mothers and underweight babies. Something similar to that has been postulated. Most of the data of this has derived from animal studies, but still the epidemiological studies sort of support these animal studies, saying that this is a huge and real problem. It's a real-time problem for us, which we need to learn to deal with. What was also interesting, I just put this slide in here because a lot of times maternal obesity is just thought that the problem ends after the baby is delivered. But it was very significant increasing juvenile diabetes. And if you see the two graphs, the one on the left side is for mothers who had GDM or diabetes during pregnancy. And the other one was the percentage of people who ended up having diabetes when the mother was obese. So if you look at it, obesity had a higher chance of a child or the offspring having juvenile diabetes than if the mother had diabetes during her pregnancy. So a very significant contribution to juvenile diabetes, maternal obesity was. So like I said, it is now postulated that most of these adult complications that we see because of maternal obesity is based on epigenetic modifications, which happen in utero due to the effect of maternal obesity. And this is the environment which has caused changes, which has then resulted in the child having long-term problems. So I'm just going to very quickly touch upon epigenetics. I'll try and see if I can explain in a very basic manner, and a lot of you may already be aware of this. So just a little background of this. Most of what happens to most of us is based on two important concepts. One is nature and the other is nurture. Nature means what we have inherited from our parents. Nurture is what the environment influences us to do. But what epigenetics and most of the animal studies have shown that the nature has even more powerful role, and it may actually change your genes. It may make modifications to your gene, which may then be passed on to your offspring and may have transgenerational problems. And this is a very interesting concept, and I'll try to sort of simplify it in the next few slides. As we all know, DNA are small chunks of your gene, and as we know, there are genes in every single cell of our body, and these chunks of DNA actually control how our body builds up different organs or how our organs function. So they basically control most of the functionality of our bodies, controlled by these chunks of DNA. So during our process, during our process of living, depending upon what we are exposed to in the environment, certain changes can happen. Epigenetics means on top of our genes. So, for example, if it's obesity, smoking, alcohol, whatever environmental influence that we subject our body to, it can bring about changes in our genes. In the sense, it doesn't actually change the structure of your DNA, but it gets certain chemicals like methylation or histone addition or changes in the messenger RNA, which come and sit on these genes. So they actually just come and sit on top of the original genes. They do not actually change the structure of our genes. They just come and sit there. They act as a switch which turns on or off. It may be good or bad. Both can result. Suppose you exercise, it may be a good thing which is switches on. If you don't exercise or if you are obese, then it may turn on a switch which causes obesity. So these switches, these epigenetic changes, or they don't actually change your gene, but they just sit on top of your gene, and they act as switches which turn on and off depending upon the environment in which you are based, or depending upon what you subject your body to in terms of exposure to chemicals or exposure to obesity, underweight, etc. So your lifestyle actually determines which genes get switched on and off. So how much you exercise, smoking, alcohol, all these things will cause these genes to get activated. So they may also turn off. Suppose you're obese and then you control your obesity. These genes which have been switched on actually change, they switch off. So it's not like a permanent change. So your lifestyle, depending upon how you change your lifestyle, your genes can function differently. And the importance of this is that when during fertilization, when a zygote is formed, during the process of meiosis, a lot of these epigenetic tags which are already attached to you because of your lifestyle, they do tend to get washed away, because during the process of meiosis, a lot of these epigenetic tags are disappear, because like I said, they're not permanent changes in your DNA. But of course, sometimes some of these tags can remain on and can be passed on to the progeny. So this actually opened a very important topic of discussion, that we always look at only maternal obesity, but obviously you can get tags from your father as well. These epigenetic tags can be passed by the father as well. So maybe paternal obesity or paternal lifestyle disorders are also equally important. And this is something that people are now looking into. So epigenetics is a very a niche field, and there's a lot of work happening in this field. And people are looking at how it's going to affect the long-term outcome for all of us. So these genes which are passed on to the child are now known as imprinted genes. They are the epigenetic tags which have been imprinted onto the baby's DNA, and it has now become a part of the baby's DNA. Again, based on the child's lifestyle, these genes can be switched on and off. They are not permanent changes. And that's the importance of epigenetics. We can make changes. They're not permanent changes, and these can be altered at any given point in time based on your lifestyle. So the moral of the story was that the environment and lifestyle choices of the parents actually modified the genetic code of the offspring, which we thought was not possible. We always thought that what parents had were passed on to the child, and this is what we had inherited. But now nature has come into a very important role of changing what happens transgenerationally. So what epigenetics is teaching us in a nutshell is, we have always traditionally believed that what we have inherited is what we are. But what epigenetics is teaching us now is nothing about us is written in stone. We are all a work in progress. Only constant is a change. Epigenetic modifications are dynamic, and they change. These switches switch on and off depending upon what you subject your body, what influences you subject your body to. And how we interact with nature not only influences our genes, but most importantly, that of our offspring. And I think that's a very important point to note over here. So what is the impact of maternal obesity and epigenetic modifications? Like we discussed before, significant environmental influences like diabetes, obesity, underweight can have a direct impact on the baby in the uterus. And the direct impact, say for example, of obesity could be macrosomia, stillbirth, high birth weight, congenital anomalies like we discussed. But at the same time, there can also be epigenetic changes that happen, which is the methylation of the genes, which causes these epigenetic tags to get attached. And although these happen in utero, they may not manifest. These problems may manifest only in adulthood, and they are responsible for the developmental origin of adult diseases, such as diabetes, obesity, cardiovascular disease. So a hostile uterine environment not only resulted in problems which happened immediately after birth, but in the long term as well. So once we have these epigenetic tags, is there any way in which we can modify this? Suppose the mother's been obese for most of her life. Are there anything, is this a permanent problem? No, this is something that can be controlled. However, the critical period of weight control to stop these epigenetic changes will be preconception. So even before she conceives, and that's where counseling is very important. We need to counsel them and say that it's not only important to start your baby out at birth, but if you control your weight, you can even change your baby's future for the rest of their lives. And I think that's a very important point to be noted. There's also some argument that if you control your weight during the first trimester, also it may help in turning off some of this epigenetic tags. However, the second and third trimester has little effect, but of course it has effect on the direct effects, which is the neonatal effects, but it may not change these epigenetic tags. There's also a period in the neonatal period, even when the baby is born with these epigenetic tags, they can be switched on and off. And one of the very important factors which helps us switching off these epigenetic tags may be breastfeeding. Again, most of these are based on animal studies, but they are very encouraging. So breastfeeding is very important, not only in terms of the immediate nutrition, addressing the immediate nutrition problem of these babies, but also in the long term, it may switch off these tags. People are also looking at folic acid supplementation and growth hormone supplementation, but these are always, they're all in the very sort of initial stages of trial. But I think coming to the end of my talk, I think the important take-home message is that maternal obesity is not a problem only for the immediate neonatal period. It has huge long-term problems. It has problems which can move on from one generation to the other and increase childhood obesity and adult diseases later on in life. And it is very important as healthcare givers for us to understand these long-term effects and sort of counsel and control maternal obesity as much as we can. Thank you very much.
I also welcome our chair, Dr. Chong from Singapore.
Hi, thank you for that wonderful presentation. I think globally in many countries from first to third world, the problem of chronic diseases just continues to overwhelm us. And for example, in Singapore, our diabetic and obesity rate has just been going up in the last 2 years with COVID. It's now 10-11% of the population for both. And I was just looking at some data that a family history of diabetes increases the risk by 2.7 times. If both parents are diabetic, 5 times. Mom is diabetic 4.7 times. If mom is younger than 50 years old and diabetic, which is probably tied in with maternal obesity as well, 6 times. And SIBS, if you're a brother and sister, it's 3 times. So certainly what you said about epigenetics and maternal obesity and diabetes is a really challenging problem we're having anywhere from first world to third world.
Yeah, I think it's a universal problem now. It's just not a problem confined to developed countries, which is what it was believed to be. And like I showed, some of the data is now coming out from Southeast Asian countries as well. A lot of these countries like India, Bangladesh, Pakistan have reported a very high incidence of maternal obesity and the subsequent mortality figures, like the perinatal mortality figures. These are basically from Asian and Southeast Asian countries as well. And I think the important business is about the long-term effects of how it's going to affect. Even if the child is fine during the neonatal and the infancy and childhood, you may still end up having problems later on in life. And I think a very important, a lot of work has been happening towards paternal obesity as well, as how it may affect us in terms of the epigenetics. So it's a huge field where a lot of work is going on right now. Most of them are animal studies, but they're still very important, I think, in practice.
You see, in Singapore, for example, we reached first world in 50 years. We did it in one generation. Whereas a lot of countries in Europe and US, for example, they took several generations to reach first world. Yeah. So we did it in 50 years. And honestly, I think our bodies are just not equipped to handle. You see, when we came out of World War II, my parents' generation, for example, they were starving. They had starvation. They went from starvation to first world in 50 years. So as a result, I think the bodies just can't handle that huge shift, that huge shift in 50 years. And we see this now, I'm sure, in cities in India, where they went first world in 20 years, right?
Yeah.
From rural to first world in 20 years in big cities. So, across big cities in India, China, for example, we're seeing the same issues. We're seeing huge obesity rates, huge diabetic rates, because the body just can't handle that change in 20 years, to go from near starvation to a land of plenty. I mean, that's my own personal view.
I think it is also a shift in the diet patterns.
Yeah.
From an essentially, like we are moving towards Western diet.
Yeah.
With more of preservatives, and so I think it is that plus lack of physical activity.
Yeah.
You are just simply on the net all the time.
I also think an important part was a lot of us have been living in ignorance with the impact of obesity, and people are only learning now, even as healthcare providers. Most of us were not aware. I was extremely surprised when I looked at the data which showed that an obese mother had a higher chance of having an infant with juvenile diabetes than with a mother with GDM during the pregnancy. So I think it is what we are still learning, a lot of this stuff. And everybody just thought obesity is to do with the mother's size, mother's figure, what is going to happen to her. People knew a little bit about neonatal outcomes, maybe stillbirth and congenital defects. But we are now learning that the long-term impact, and I think that's very stark of what is going to happen to a lot of these infants born to obese mothers. I think that's a very important aspect of what we're trying to do. Even as healthcare professionals, most of us are very ignorant about it.
I did an internet medtech startup about 3-4 years ago. I started an internet medtech startup. We used the Abbott Libre. You can see this Abbott Libre, right? And we used the Abbott Libre and we attached it to, we have now done 400 patients. And we made them log the food with the Abbott Libre tracings. We log the food on a WhatsApp, on an application, mobile application. And we see that the problem in Singapore, for example, our 400 patients, is actually a lot of them are eating our street food. And the street food here is a killer in Singapore. So all their sugars are spiking like crazy. And the moment we tell them to cut out those foods which are spiking their sugar, the insulin comes down and they start to lose visceral fat. So we've now done about 400 patients in Singapore. And I tell you, it's fascinating data. So the problem we face, and things like white rice is a disaster. White rice, white bread, potato, yellow noodles. Our white rice here is a glycemic index of about 98. And 200 grams of white rice is about 60 grams of sugar. You only have 5 grams in your blood at any given time. If you're diabetic, it's 10 grams. Sugar is tightly controlled. So it's just amazing. I mean, we're seeing all this data. And for example, white bread is 105 grams for 200 grams of white bread, 2 slices. Potato is 40 grams. Our yellow noodle, which includes instant noodle, by the way, is deadly stuff. It's 146 grams of sugar. 200 grams of instant noodle is 146 grams of sugar. It's near almost pure sugar. So I don't know what to say, but it's a disaster here for our street food. And it's cheap, but it's only maximized in flavors and carbs. It's a disaster for diabetes and obesity. I don't know what to do. Dr. Akhtar, you have something to say.
Good morning again. Thank you very much, Dr. Madhu and Dr. Raghunath. Excellent presentation. I just wanted to know on your experience in obstetrician. practice, what was the infertility rate in the super obese and obese patient? That's one. And during pandemics, COVID-19, have you got any statistic or data? What happened? Those superwomen, super fat women had a COVID-19, and what is the outcome? And from the pediatric side, I'd just like to know, is there any relation with the obese babies with the sudden infant death? Thank you.
All right. So I wouldn't be able to tell you the exact percentage of infertility in obesity, but it is a well-known fact that there is a higher incidence of infertility in obesity, and more the weight, the more likely infertility. In fact, even if you sort of look into the data of polycystic ovarian disease, it is a well-known fact, a practical fact, that if the patient loses 10% of the body weight, they tend to get naturally pregnant. So definitely pre-existing BMI, it is not only for natural infertility, even for IVF rates. There is a lower success rate when you sort of do an IVF in super obese as compared to obese or a normal weight patient. Now, coming to your second question, COVID and obesity, we all know that obesity makes the patient high risk for any long-term or even short-term complications of COVID. And ICU admission rates are more, hospital admission rates are more if the patients are obese. And coming to mothers who had COVID and were obese and were pregnant, they had a very bad time in COVID. I remember losing a patient of mine who was obese. She was 43-year-old, late pregnancy. She had COVID, landed up in the ICU, and eventually, despite all efforts, we lost her. So definitely obesity is a high risk factor as far as COVID is concerned. So about the pediatrics, I think Dr.
Sorry,
Rahul
yeah.
will answer.
So obviously during COVID, there was a huge incidence of childhood obesity that I think goes without saying. There's been a huge jump because most kids have been staying at home, eating food, not exercising. Most of them have not gone out for 1.5 to 2 years. There's definitely an increase. I'm not entirely sure about the incidence of sudden infant death syndrome. I can't remember it right now, but I think I've not looked at it particularly, but I think from what I remember that if there was an obese father or mother, it increased the chance of SIDS. But I do not know by exactly what number. So I don't think I'll be able to quote numbers for you there.
Dr. Bukhari, you have something?
Thank you very much. First of all, I appreciate Dr. Madhu.
Your voice is not clear.
Talk.
Your voice is not clear.
I have one comment and one. You are hearing me?
No, Dr. Bukhari, your voice is
you are
not
hearing
clear.
me? Hello?
Yeah, okay.
Okay.
Can you close your camera and speak?
Okay. Okay, now if you are hearing me?
Yes, better.
Yes.
Hello. Okay. Thank you very much. It was very nice talk. I have one comment and one question from you. During my parent time, before the when the India and Pakistan was subcontinent, the obesity was sign of beauty. It was sign of beauty. It was when selection of a wife for the even my father was saying that जो बीवी हो वो तकड़ी होनी चाहिए at that time. Okay, this was the sign. But now it is becoming a stigma and creating a more lot of problem. Why this is now happening and it was not happening in that time? This one question. Second question is that you have advised a vitamin D and folic acid. Is there role of any reducing the obesity or just reducing the risk factor? Thank you so much.
So answering your first question, I think obesity more than a sign of beauty was considered as a sign of prosperity in that time.
At that time.
Because, like Dr. Chong just pointed out, that
Yeah.
we've gone from a land of absolute starvation to a land of plenty. So it was considered that people who have obese have more food to eat, and so they are more prosperous. I think so. Wife selection or bride selection would be related to that fact rather than the actual beauty. But yes,
But it
obesity
is
at
not
that
happening
time,
now.
correct,
No, it is
correct,
not happening these days.
correct. Because I think, we generally tend to take obesity as a number, as a BMI, as an absolute weight. But if you look into what the dietitians are saying now, what the study of nutrition is, it's more than, a calorie deficient or a calorie gain diet. So there has to be a little bit more nuances to it, which we've still not caught on. It might be the proportion of the fat to the muscle. That might be different because I'm sure that time the women were more physically active, so their muscle mass must be more. It may be related to that kind of diet. I strongly believe that the more fast food or what we call the junk food we eat, the poorer our health is. Right? There are so many studies which show that even if your BMI is normal, you're not necessarily healthy. So I'm sure there are nuances which will come out in the future as we go on and as we recognize that it is becoming a problem. We'll pick on more on what role the diet and physical activity actually plays. It is not just a number, I'm sure. It's not like 100 calories of ice cream is not equivalent to 100 calories that you get from an apple. So I'm sure the future will bring us, it will shed more light on this fact. Now, the second question, could I have it again?
Is there any
Yeah.
role
So
of
folic acid
B
supplementation
in
prior to pregnancy
reducing
is
the obesity?
correct. It does not reduce the obesity. The supplements are given to reduce the incidence of congenital
It is
abnormalities in
only
the
to
baby.
reduce the risk.
Yeah, it is
Okay.
not given.
Can
It is just
can I
because
add one comment? Yes. Can
yes, sir.
I add one comment? Because in previous, if you go 50 to 70 years back, the woman no doubt have a more physical activity as compared to the. Another thing was the diet was natural in our Eastern country.
Correct.
In our Eastern, they use the word desi ghee. That was they were using the natural diet. But why in those days? In nowadays, we are using the prepared artificial or pizza or something else. This is the more problem in the Western country. I think the people will once again come back to the Eastern diet. The Eastern diet is more protective as compared to the Western diet. Thank you so
Yes,
much.
so the studies have definitely shown that the desi ghee has short chain fatty acids as
Yes,
compared to vegetable oils,
yes.
which are not good for our health. So, I'm sure we are missing out on the relation of diet to the environment. There are so many things, It is locally produced food. It is how it is cooked, what temperature of cooking. Actually, if you look through it, it is a fantastic field on its own. So when you eat, we are slowly coming around to the timing of eating. There was a time when in our households we would not eat after sunset. Now a late night dinner is actually a feast. So food is more than just a calorie game. It is the type of food, it is how it is cooked, when you eat, the quantity, and I'm sure it depends on the person who is eating, on their personality. It just doesn't make sense. The same family of five eating the same food and the same kind of physical activity have different BMI. So I am sure definitely we will be more enlightened in the future regarding all of this coming together.
So if I
Thank you,
can just come in slightly different perspective of this, I don't think it is to do with Eastern diet, Western diet. I mean, that might be a point, but I think obesity has always been there. We've been ignorant about the problems of obesity, and we're just now discovering that these problems are happening. I'm sure these problems are happening in previous generations. Obviously, like we discussed, rate of obesity was much lower in the developing countries. but this problem has always been there. We are just learning the effects of it now. It is not that it was not existent before, and it's a new world problem. Obviously, the proportion of the problem has increased quite dramatically, but these problems have always been there. It is like the simple saying, ignorance is bliss. So we were not aware of it, and we thought that the problems were just for that person. Now we are learning that these problems can pass on to the next generation as well. So I think these problems have been there. We are just understanding it a bit better now.
Yes.
True. I agree. It can be a mix of both. But both the things are there. We would never see obesity in lower socioeconomic strata, whereas now it is very much there in the lower socioeconomic strata as well.
Yeah.
So, let's see what the future holds.
Thank you very much. It's a fascinating and complex topic. I mean, the both of you, thank you very much, Dr. Goel and Dr. Maria. Correct. Sorry. I think in the interest of time, we're running a bit short on time. So thank you very much for your wonderful presentation. And I will look forward to meeting all of you in person. And, also to our next meeting next Saturday. But thank you very much for have taken out some time to give us this wonderful talk. It's of such a tremendous value to all of us, because it's a huge problem in every country, be it first world to third world, and definitely a huge challenge ahead for all of us. Yeah. Thank you. Thank you so much.
Thank you very much.
Thank you very much. And it was a delight to be here.
Thank you so much.
Thank you.
Bye-bye.
Thank you. Thank you.
And see you again next week.
Yes.
Yeah.
Bye-bye.
See you next week. Thank you all. Namaste from Nepal.
Yeah. Namaste.
And these terms are comparable terms. When you compare two things, then you say one is medial, one is lateral. It does not mean the thing which is medial is always medial to everything. No. It's a comparison. Like if you look at my